Good afternoon. I'm Catherine Santoro, Director of Policy and Development at the National Institute for Healthcare Management Foundation, and I'm very pleased to welcome you to our webinar, The Virtual Visit, How Telehealth is Reshaping Care Delivery. Today we're joined by an esteemed panel of leaders who are guiding efforts to increase access to healthcare through virtual visits for patients all across the U.S. Before we begin, I would like to thank NIHCM's President and CEO, Nancy Chalkley, who led the development of today's webinar, as well as the NIHCM staff who helped convene this event today. You can find biographical information for all of the speakers, along with the agenda and copies of slides on our website. We also encourage you to use the hashtag Telehealth to live tweet during the event this afternoon. At this time, I'm pleased to introduce our first speaker, Senator William H. Frist, a nationally acclaimed heart and lung transplant surgeon, former U.S. Senate Majority Leader, and Chairman of the Executive Council of Cressy & Company. He is engaged in business as well as the medical, humanitarian, and philanthropic communities, and he's also a member of NIHCM's advisory board, and we're so pleased he's joining us today to share his perspective on telemedicine.
Catherine, thank you very much. Thank you very much, and it's great to be with everybody for what's really an exciting hour and a half, looking over the speakers that are to follow, and then with questions and answers at the end. I'm going to do a little scene setting and then use a few examples, but basically spend my time looking at the challenges that we have in the current landscape, and secondly, looking at telemedicine as a solution. Thirdly, the case study of Teledoc. Throughout the other presentations, there'll be lots of other examples, so I'll use Teledoc just very briefly as a scene setter for what is to follow. The current medical landscape, the problems are really four as I see them. Number one is the lack of access. 80% of adults discharged from an emergency department in one study were due to a lack of access to other providers. So we naturally ask the question of what would happen if there was some other option. We all know from our policy studies these huge pockets of underserved. For example, there are 200 counties in Texas that are designated medically underserved. 16 counties have just primary care. 27 counties in Texas, none at all. Yet in truth, if you step back, given technology today, everybody in each of those 27 counties where there are no primary care doctors, or 16 or the 200 underserved, are within 10 minutes of talking to a fully boarded, fully trained, fully licensed physician in their state within 10 minutes. The second big issue is that of the physician shortage itself. We all know it. The 52,000 on the slide there on the right lower corner is an approximation, but if you look on the left, it signifies the demand because of population growth, the aging of the population, which is a wonderful benefit to where we are today in society, and the increased access with the Affordable Care Act and the aggregate around the country. That's a reflection of the increased demand, and whether it's 40 or 50 or 52,000 primary care physicians, we know, and we're using physicians as the measure here, but we know there is a provider care shortage. That's problem number two. Problem number three, the cost of care. We don't really say anything else other than the cost. Spending continues to increase. The people around the country are saying spending is flattening out, but this slide, which was produced by the Kaiser Family Foundation, of which I'm on the board, but Drew Altman released it yesterday, is a fascinating slide. If you look at the right, this is year-over-year growth in health services spending by quarter, and you can see since the first quarter of 2004, it's gone from 2% growth to 3% growth the next quarter to 5% growth the next quarter to 5% to 7%. The whole point is that cost and spending pressure is increasing now. It's on the rise in the last 5 quarters, and that is the reality where we are today. The fourth big issue, again, it's an obvious one, is that the out-of-pocket cost is so totally different than 5 years ago or even ago. The out-of-pocket costs mean that the burden of that first dollar coverage, no matter how good the insurance is in terms of the number of insured, that burden of the cost of that deductible, which is now typically $3,000, $4,000, and $5,000, is resting with the consumer. And as the consumer or the individual or the family with these deductibles continues to rise, care and access to care is going to fall, as you can see from that first box, unless it is lowered by some alternative out there. And of course, the alternative we're speaking to today is telemedicine. A solution is telemedicine. What is it? We'll all have our different definitions. We know what it is that it revolutionizes how consumers access, use, enter, execute within the healthcare system by delivering access remotely, not right in the presence of bricks and mortar necessarily, to care that is more affordable, that's of equal quality, of high quality, and then I add there when, where, and how the patient chooses, because the patient really has other barriers, whether it's cost or 2-hour drive, transportation, or waiting rooms, or parking lots. All of that disappears. What is telemedicine? It is not the practice of medicine, and as a doctor who's been in the field and practiced medicine extensively for years and years and years, it's probably the hardest concept I have in communicating to other physicians. Telemedicine is a tool. It's not the practice of medicine. It's a tool that allows doctors, physicians, others practice medicine for the care of the individual patients who are located maybe a block away, or 5 blocks away, or 10 miles away, or 100 miles away, or 1,000 miles away, or around the world. It can be done when we say telehealth. People think just video. And as a doctor, I used to think, well, video is not going to quite do it. You got to touch the patient. You got to examine the patient with your hands. And then video, sort of, is it going to really work? And the answer is yes, it works. And then now what we realize, for most conditions today, you don't even absolutely have to have the video. Whether it can be telephonic, it can be other types of communication. It's up to the standard of the individual doctor to determine whether the standard of care can be met. I think it's very important for telemedicine, to the technology end of it, allow the physicians to be making the ultimate standard of care decisions, and that's exactly what it does, because the technology is just a tool. The last point is that there are now, unlike 5 years ago or 10 years ago, many studies with robust quality measures showing that equal, and in some cases better, care in the medical literature are being through remote access. Telemedicine, where's it going to go? Again, these slides are going to all be available for people, so I don't need to go through and read each one, but just looking at the points, it's huge. It's going to grow. It is growing. There are certain barriers out there, but it just makes too much common sense. 62 million people without primary care today. We have, yes, fewer uninsured, which is a very positive thing, but as I implied, with higher deductibles, not everybody with insurance is going to be accessing physicians, especially on the preventive side, or getting disease early, if they have to drive 3 or 4 to wait in an emergency room for an hour, or exaggerate, but that's what happens in many counties, or have to pay an average $14 emergency room bill when they would have an alternative. 33% of all office visits, that third bullet there, are potentially addressable with telehealth today. Again, 1 out of 3 office visits are relying on telemedicine extensively. 71% of employers with more than 1,000 employees will offer telehealth in the next 18 months. And then the last point, the telehealth market seeing record growth. Most people will say that the overall market's going to grow from somewhere between 20 and 30 and as high as 35% a year. People are interested. Attitudes are changing. In the U.S., they've gone this huge shift in recent years. A recent survey by Kiosk shows that 76% of patients prioritize access to health care over the need for human-to-human live in-person interactions. 70%, almost three-quarters of patients are comfortable communicating with their healthcare providers via text, electronically, email, videos, versus seeing them in person. There are barriers limiting the telemedicine, huge consumer demand, the medical profession increasingly comfortable with it, although most of us weren't trained with it, and therefore there is a cultural shift for people like myself, physicians and nurses and social workers. It's like everything else, technology takes change and adoption with culture. The two most limiting sort of restrictions to its spread are the ones centering around and visit at the top of that slide, and then the licensure, which is by state below. The in-person visit, which has gotten a lot of attention recently, requiring an in-person exam and visit before any remote follow-up is allowed. That's a huge barrier, because what you're doing is basically saying if you live 200 miles away that you need to come see a doctor face-to-face, almost in essence like getting a prescription, and then in order to be able to middle of the night at 2 o'clock when your child has a bad cough and you don't know what to do. It's just so impractical. So in the licensure, increasingly getting together and putting together regional cooperatives in terms of licensure acceptance, and I think there'll be more and more of that as we move forward. Briefly, and this is the third section, the case study of Teladoc, and let me say right up front, just so there's no, so it's clear, I am Teladoc and chose to be on that board because it is one of the larger telemedicine firms that are out there. I do want to put this disclaimer that since I am on the board, that anything that I say here is solely for illustrative purposes, educational purposes, and institutes an offer to sell or soliciting an offer to buy securities in any jurisdiction. The process is straightforward. Again, you'll hear several other examples today. They're all the same, and that you can go computer or phone, complete very quickly. It takes maybe 2 to 3 minutes, depending on how extensive that is. You request a consult. In a short period of time, you are, say, within 10 minutes. It might be 6 minutes, it might be 15 minutes, but it's very quickly with a physician that is licensed in the state, licensed nationally in the state that you're talking to, who is, as I said, board qualified, or board has their boards in the specialty. The issue is talked about, resolved. That can take an hour. It can take 10 minutes. It can take 15 minutes. Everybody knows when it could take just a few minutes, or it could take a much longer time, but typically it's in a period of minutes, say 15 minutes. Continuity of care is established by the physician in consultation with the patient, and then settling up to make sure that there is follow-up and whatever financial arrangement has been made or agreed to in that particular case. So it's very, very straightforward. As technology improves, it becomes easier and easier. Can be done mobilely, can be done on the cell phone, can be done on tablets, and can be done by computer and by telephone, just with 800 number. This is an interesting slide just as we talk over the course of the hour. The most uses on the left, the top 10 diagnoses, and this is from about 1 million patients or 800,000 patients. If you just look at what the chief complaint or the primary reason for the call is, it is things like sinus problems, urinary tract infection, pink eye, then upper respiratory illnesses like bronchitis or the flu or cough, and nasal congestion, and then ear infection. But if you look, overwhelmingly it sits in the sinus problems, urinary infection, pink eye, and bronchitis. I mention those because once you hit an emergency room with a $400 admit fee, a consultation, usually a blood screen just when you walk in the door, before you even see the physician, you know these are the sort of problems that can be diagnosed much more easily than in the standard steps that you take when you hit an emergency room. Looking over to the right side, again, I don't need to, it's no help to go through them directly, but let me just pick a couple. You can either do electronic or by phone. Yes, drugs are prescribed. If you go on down to the second to the last bullet, you see that Teladoc does no prescribing of narcotics, DEA-controlled substances, medications for psychiatric illness, or lifestyle drugs. Company to companies vary, but those are areas that Teladoc does not prescribe in. And the last bullet, generic drugs are frontline drugs and the ones that are recommended unless a generic drug simply is not is not available. The second bullet I have prescribing lower than the same diagnosis when comparing best provider practices. I'll qualify that a little bit. I'll say comparable. In the antibiotic field, as all of us know, everybody needs to use less antibiotics. The recent RAND study out shows that Teladoc uses antibiotics at about the same level for a group of the illnesses as in best of practice in a community. The things that is pretty neat about the telemedicine, when you're seeing hundreds of thousands of consultations, you really can do best practice. You can monitor best practice, evidence-based guidelines. You know they're applied consistently, and then you can do ongoing quality review of each and every interaction because it's done electronically. The RAND study from 2015, just look at the last two, 21% of visits were made by patients who had not accessed health care in the previous year. It kind of says, why do you have to go to a doctor in their office in a building to get permission to use telemedicine? It's one that kind of just doesn't make sense. And then the last bullet, 25% of patients who did not have a telehealth service benefit actually went to the emergency room as their next best alternative for care. In other words, you haven't signed up, you didn't access telehealth, you couldn't access them. Where are you going to end up? You're going to go to the emergency room, and the average charge for these emergency rooms is about $1,400 a visit versus what might be a $40 phone call or a $30 or a $50 or $60 phone call or video interaction. Huge cost savings as well. To just grow, this is just an example of Teladoc growth, and I use it as an example just as a case study, but there's sort of 5 big telehealth. And a lot of people, as we'll hear from the other speakers, are using telemedicine, telehealth, telemonitoring in other ways. But if you just look at the top box there in 2013, 127,000 consultations, and then in 2014, 298 consultations. You see the huge number of people who are taking advantage of this new technology. And then in the left two vertical boxes, you see that 8.1 million people are on the Teladoc platform today and could tonight, if there's an illness or something not going quite right, could access a doctor within 8, 9, 10, 15 minutes if something goes wrong and they need that sort of care. So lastly, why the growth? Consumers are demanding more convenient care. Employers and plans are flocking towards it because they want to be able to provide the best care at the lowest cost for their employees. Telehealth offerings are more sophisticated. The user satisfaction net promoter score type measurements is sky high. Lastly, consumers want it. They're speaking loudly. They desire it. They see the benefit. They want to access primary care on their terms. Telemedicine offers this opportunity with maximal convenience to the consumer, whether it's drive time, financial, green barriers. They know that equal or better quality cost. And there's true cost savings to employers and health. In 2015, 50% of large employers will telemedicine in their health plans. And my sort of bottom line that I sort of summarize it all with, telemedicine is indeed transforming health delivery. Thank you very much.
Thank you so much, Dr. We'll move to our next speaker, Dr. Karen DeSalvo, the Acting Secretary for Health in the U.S. Department of Health and Human Services and the current National Coordinator for Health technology. And we're so honored she's able to be with us today to share current federal efforts to improve access to care through telemedicine.
Well, thank you all for the chance to share our perspective and work in the space of telemedicine. And thank you to Senator Dr. for his presentation. I think that you'll find that we have a alignment with those general principles here at HHS. I thought what I would start with is perhaps a broad frame of our focus within HHS and talk about how health IT fits into it. And then we'll walk through some of the specific ways that we're working to weave telehealth into our policy and technology efforts going forward. Just a broad pickup on where Senator Frist left off, which is that consumers are demanding appropriately and with an increasingly loud voice that they have better care, smarter spending, that they can be healthier using more and more innovative tools that allow not only health care but health to be more accessible to them where they live, where they work, and where they're just trying to get the course of their daily business. And the healthcare system is working along, and I think it's incumbent upon us at HHS to make sure that we're doing that in a way that is really increasingly meeting expectation, but is allowing that kind of innovation to flourish, but that we're seeing that it is also becoming more routinized. To that end, as we're working through getting to this place of a better care, one where the kinds of statistics that you saw in the last presentation are flipped, where quality is great and the cost is down, and access to great services. We've been working on reforming the delivery system through a pathway that seeks to change the way that we pay for care, the way that care is delivered, and the kind of the way information is distributed. The paying for care is really about changing to more of a value-based system and away from volume-based or transactions. That pathway and specific goals we set in that area to move the healthcare system into population-focused payment over the next few years, such that by 2018, 50% of payments to providers from us at and Medicare are in the bucket, that value-based, we believe allows for more flexibility and innovation in care delivery in the care system between doctors and their patients in ways that are going to allow for the flourishing of efforts like telehealth and other telepresence opportunities. Secondly, we want to make sure that in the better care space, we're supporting and encouraging development of models of care with evidence-based to tell working better for consumers and for doctors. They're more cost-effective, and we'll be continuing to support through grant programs and technical assistance and bright spotting just to let folks know where good work is already happening. And thirdly is our work to advance the care system and improve it through the Health IT Foundation. And this is really where the work of the Office of the National Coordinator gets quite intensely focused. That work is our responsibility as an HHS family member is not only to coordinate across Health and Human Services, but across the federal government to set the tone of policy and technology for the work that we do and the work that we want to do in partnership with the private sector. I'll walk you through a couple of big ways that we've been doing that in the last year and a half that are inclusive of telehealth, to give you a snapshot of how we're looking to really advance the strong foundation this country has built in electronic health records to digitize the care experience of all Americans. This work over the last 6 years has meant that, for example, about 97% of all hospitalizations have an electronic record of it, and about two-thirds of outpatient visits together into a broader picture of health. And more importantly, the world has well beyond electronic health records as the electronic platform. There is a broader health IT universe that we need to take into account. Telehealth is one of many tools that we need to make sure we're bringing to bear to get this full digital picture, this picture of somebody's health, more than just a healthcare experience from the electronic health record. As we're thinking about telehealth at ONC and how we're working with our federal partners, I just wanted to spotlight a few key areas. One is that we believe that we can further telehealth adoption and interoperability through a set of policies not only related to the technology and to area privacy and security, but by working with partners like the USDA on helping to advance broadband access. Secondly, we're looking to incorporate telehealth and in our emerging and advanced health models that we're developing, whether that's through payment or through technical assistance for better care models for programs like our Medicaid and Medicare programs. Thirdly, we're looking to expand access to health care and improve health equity generally, whether that's through our programs in the Indian Health Service or the Federally Qualified Health Center or Rural Health Hospital and Critical Access Hospital programs. Telehealth is a critical underpinning for so much of the access and opportunity for those populations in not only physical health but also in behavioral health. And fourthly, looking to see all the while that we're protecting privacy and security for Americans as they're engaging in not only health IT but also in the broader world of health information technology that's supporting their overall health and care. The priority for us in this last year has been in the space of interoperability. Why? Because the 6 years of some nearly $30 billion investment in electronic health records to lay a digital foundation for what is a sixth of our economy, that information is available when and where it matters for the consumer, for the doctor, for others on the care team, that will help us reduce unnecessary redundancy, that will help us to reduce unnecessary redundancy, and that will help us to get the right quality and care information available to the constituents who need it. That means in many ways that it reduces the burden for needing to go into additional visits. But we also want to see that we don't focus at connecting the electronic systems. Our interoperability roadmap that we released last January and that we'll have a new version of this fall specifically points to the fact that we believe that a critical part of interoperability is going to be that we have to have telehealth adoption. It's going to help us get to a learning health system that is working iteratively to improve health and the quality of care and the accessibility and availability of care and get us to this better care, smarter spending, and healthier people. The language specifically from the roadmap, but we spelled out here on this slide that a learning health system also incorporates advanced health models that increasingly leverage technology such as telecommunications technology to deliver health and clinical services remotely that improve access to care across clinical and non-clinical settings. Interoperability has been a priority for us. We are, of course, as I said, looking at the short-term across institutions, a platform that allows for a broader health IT ecosystem to connect care. We are also at ONC developing the Federal Health Strategic Plan, which is a much broader look at all the inputs and outputs to a strong health IT infrastructure for the healthcare and health economy. And that draft plan includes 35 different departments and agencies across the government that do include groups like the USDA, which has an interest in rural communities, all the way through to Bureau of Prisons, which has an interest in a storied history in using telehealth as a strong tool. That for those of you that would find the draft and the soon-to-be-released final report on our website, you'll see that our strategic plan as a federal government is one that seeks to work across our federal partners to leverage technology to advance access to care. We have some draft goals in there that talk about the adoption and use of health IT, including telehealth and mobile health, that we want to advance a national communication that supports health, safety, and care delivery, including the ability to deliver telehealth solutions. We to improving care quality experience through the safe, timely, effective, efficient, equitable, and person-centered care, and that point to telehealth as one of the important tools that not only the federal partners are already using, but that we'd like to see spread more in the country to increase access to care. I'm going to end on the final place that Senator Frist spoke about a few times. That is always central to the work that we do here at ONC and HHS, which is about the consumer. That's why we get up and come to work every day, is to make life and care better as much as we can for everybody in this country. And what I hear when I go out and do listening sessions and meet with people and see my own patients in clinic is the same themes that were already raised by Senator Frist, but it's worth underscoring, and that is that they have a sense of impatience about the way the health system is not always to them and requires sometimes extra steps for them to get their basic needs met. I think if we're going to improve their care experience, improve their health, and reduce cost, it's put on us to keep pushing forward, but also to make sure we're systematically listening and building a consumer-centered experience, whatever that is. In this case, we took the time in April to on consumer-centered telehealth and the e-visit experience and understand how we would policy and technology in partnership with the sector in a way that we would be understanding how we would design and enable a more consumer-centered telehealth experience, that we would identify those challenges in the current state that may be payment for telehealth, it might be licensure issues, or perhaps care fragmentation that tools like telehealth and telepresence could really help to overcome and really help us understand what design principles that would be the right use cases as part of a future telehealth system. Again, not only for our own providers in the federal space, VA, Indian Health, the qualified health centers as examples, but really to help lead by example and partner more tightly with the private sector with all the good work that's already happening out in the healthcare space. And so as we move forward and are thinking about our strategic work, the policy and technology work, is this notion of making care more accessible, not just through expanding coverage, but really thinking about how technology can be leveraged to bring care to people in new and innovative ways, is weaving itself into all of our work and documents, and not just strategic in the rulemaking we're doing around changing the way we deliver care in our delivery reform work. I'll just end by saying that I'm so pleased to be on this call with this set of stakeholders, because we're learning a lot as we do this from what we're seeing happening already in the field and kinds of good results that are already happening. And so we look forward to continuing that public-private partnership as we're moving to get into this better care, smarter spending, and better health for everybody in this country. Thank you.
Thank you so much, Dr. DeSalvo, for joining us and for sharing that overview of some of the federal efforts. Our next set of speakers will be just a few of the many telemedicine services being offered across the country today. Begin with Howard Rochay, Vice President of Delivery System Operations at Howard.
Good afternoon, everyone, and thank you for the opportunity to present at this forum. I'm going to share two things quickly with you from a Florida Blue perspective. The first is our position on public policy to telemedicine and where we're at in that space. And then second of all, I'm going to share some of the work underway in the telemedicine space that we currently have activities in. As a means of I do want to start out by saying, hold on, I got to get the slides to move. My apologies there. Florida Blue understands and agrees that telemedicine is a growing alternative to traditional health care. We believe an opportunity to improve patient access to health care, reduce medical costs through reduction of higher cost services, and to improve member satisfaction as well as quality of care. We support the expansion of telehealth services to enhance, specifically for us, Floridians' access to convenient, affordable, higher quality health care. From a policy position, we support relaxing or at least revisiting legislative and industry barriers which could inhibit the maturation of telehealth capabilities, where doing so improves quality care and affordability. Florida Blue supports the free market approach for telehealth services, whereby payers, vendors, others in the space negotiate reimbursement and coverage terms consistent with market and customer expectations. We do, of course, or support legislation or industry actions that would mandate payment amounts, mandate member benefits, specific network participation for telehealth services. We believe a good public policy should have the following objectives. It it should address access and increase access to care, increase quality for both clinical and service-related activities, have the potential at least to decrease costs or at least not increase costs, and allow the free market to work as it does today, or enhance the ability for it to work. We also believe, as mentioned earlier, that it should support the industry's move to value-based reimbursement, where we are moving to pay for value versus pay for service, and it should not restrict the market in any way. From a strategic position internally, from a telemedicine standpoint, we support a member benefit approach aligned to a dedicated vendor-managed sub-network of providers. In the very near future, self-funded account business with Florida Blue will have the option of purchasing telemedicine benefits through the Florida Blue relationship with Teladoc. This is a recent contract relationship that we're moving forward with. I'm going to speak more about that later in the presentation. From a telemonitoring standpoint, we do support telemonitoring as a care management program where services are valuable for specific high-risk members who will benefit from the program, reducing need for higher cost services and increasing quality of life and quality of care for those members. We do not necessarily support broad telemonitoring as general benefits under all products. So from a strategic approach internally, we are introducing several select capabilities as part of our overall telehealth strategy. Our goal is to pilot test the quantitative and qualitative effectiveness of those solutions. As everyone knows, this is an emerging space, a lot of activity, so our plan is to scale up and integrate the most beneficial and cost-effective telehealth capabilities as we learn more about them and as the industry continues to mature. So what are we currently working on? We have 3 activities that I'm going to share with you specifically, and then I'll talk about some future things that we're also considering. The first activity is a kiosk in the Miami Retail Center. Florida Blue has a variety of retail centers throughout the state of Florida. We have chosen to put a telehealth kiosk in the Florida Miami Retail Center. This was put in October of 2019. Treatment offered there is for convenient care for Blue members only at this point, to treat things like cold, flu, allergies, earaches, other convenient care type activities. The network behind the kiosk is Nicholas Children's Hospital, previously known as Miami Children's Hospital. So this is the provider that provides services for the kiosk, and you can see our hours of operation there. Early evaluation, we did expect a little more traffic than we're currently getting. We continue to monitor the effectiveness of the members seen at the kiosk and the effectiveness of the services rendered there, and we'll obviously evaluate the results of the pilot in the near future, given it enough time to show effectiveness. And at that point, we'll make decisions on whether or not we move forward with kiosk in other retail centers or not. The second thing that we have active, I mentioned earlier, we have entered into a contractual relationship with Teladoc so that we can utilize their services to offer telemedicine benefits to our ASO clients. That ASO is just an acronym for self-funded clients, to purchase as a buy-up benefit. And this is administered through a sub-network of providers. This is not tied to our general network. Sub-network of providers is contracted through Teladoc. Our target effect is third quarter 2015. The third thing that we're looking at is telemonitoring. As I mentioned earlier, we believe telemonitoring is a viable solution as a care management opportunity for select members who have chronic care issues or have issues related to their health care. So we are finalizing a RFP to pilot telemonitoring program. Our initial target will be members with congestive heart failure. So these high-risk members will be identified and offered the opportunity to participate in this program based on several factors related to their health. The initial group will be for fully insured high-risk members with the the CHF diagnosis, and our target effective date there is third quarter of 2015. If the pilot goes as expected, we will continue the rollout of this activity to other disease states and potentially other members. While not mentioned here, we also are engaged in a few other activities. We are evaluating what we classify as this came to us, and it's a very recent evolution in the market where there's several vendors. You'll hear from one, TouchCare, in a few minutes, that are looking at ways providers to their own patients through different capabilities. So Florida Blue is evaluating those capabilities and the potential that might be in that space as well. So in summary, just to reiterate, we do support telehealth services and are excited about what they're bringing to our industry. We specifically are looking for opportunities to advance Floridians' access to convenient, affordable health care. And again, relaxing those legislative and industry barriers that may exist out there that could inhibit the maturity of the telehealth industry. Supporting the free market approach, trying to stay away from legislative or industry actions that would mandate as fits all across the nation. We do believe there's some flexibility and variability that needs to be considered. And then we are very excited introducing several initiatives, piloting initiatives, testing them, moving forward with the best-in-class solutions, and then continuing to see what the industry brings in this space. So that's the end of my presentation. So again, I'd like to thank Catherine and others for the opportunity to speak today, and I'll turn it back over to the...
Thank you. Thanks so much, Howard. Our next speaker is Damian Gilbert, who is founder and CEO of TouchCare. Go ahead, Damian.
Thanks, Catherine. Thanks, everyone, for joining this morning. If anyone has any questions, reach me to get copies of my slides, at TouchCare. So I'm an entrepreneur, and we're a startup in the space. So thanks to the others for talking through the sort of industry landscape, the policy, and things that are affecting us. TouchCare came from a pretty simple idea. We're a group of sort of frustrated healthcare consumers with a question: what if there's a better way to see your own doctor? We all agreed in the market that there was a good need for the services, like the senator described, Teladoc, where you can dial a doc on demand. But many families in the States have their own doctor or their own healthcare provider, their own primary care, their own specialist, their own nutritionist, their own pediatrician, etc. And so that was our question: what if there was a better way to see your own doctor? And the reasons have been talked about on this call. Really two things. First is the convenience, and second is the access. There are many times in all of our lives where if we could see our own provider, we wouldn't necessarily have to go to urgent care or to a retail provider like a Minute Clinic or a Target. And maybe we wouldn't need to dial an on if we could get in to see our own provider in a convenient way and an accessible way. So TouchCare is a really simple idea. Let people connect easily to their own providers for video appointments from any iPhone or Android device. And the way we approached it, because we're all mobile people at our company, is by building their own networks and connecting to those they know. So if you look at the slide in front of you, you'll see a bunch of logos on the bottom of the screen. And what that really represents is the way that our minds work as a sort of young mobile startup. We sat around a table and said, what are our favorite apps in the world? Many people on this line probably favorite apps in the world. And the things that we all loved about them are they're really simple, beautiful, and easy to use. They're free, and you can invite your friends. So we built TouchCare the same way. Getting started on TouchCare as a provider is really simple. You download the TouchCare app from the iPhone store, the iTunes store, or Google Play. You set up your profile, and you invite your friends. Except they're not your friends, they're your patients. And once you get to TouchCare, you can schedule a video appointment with them that's HIPAA compliant on any mobile device. Similarly, you can also invite colleagues in your Colleagues tab, and then you can either message or schedule HIPAA compliant video calls with colleagues. Setting up as a consumer is easy. You download TouchCare, you set up a profile, and you connect to your doctor. So consumers can invite doctors, doctors can invite consumers, and doctors can invite other healthcare providers. And enables you to have your healthcare network in the palm of your hand on your iPhone or your Android device. So whether you're a 1,000-provider health system or a single provider office, getting started on TouchCare is just the same. It's free, it's immediate, and you can be live the same day. The big idea with TouchCare is really just one that comes from sort of our team, and we're a small, like I said, a small startup in Durham, North Carolina. But all of us have backgrounds in mobile businesses and social media businesses. And the big idea is that TouchCare's network is actually growing by itself. A doctor might invite 2-3 patients. And some of those patients come around and say, this thing's really cool, I'm going to invite another of my providers. And then that provider thinks, this thing's really cool, I'm going to invite some more patients. The network is growing by itself, which is pretty remarkable to see. So the slide on slide 8 really sort of rams home the point that many of the other folks on this call have made, which is that if we had the ability to access our own healthcare providers, as well as all the other wonderful services like Teladoc and others, convenience and access would clearly rapidly reduce costs, improve efficiency, and help everyone meet the triple aim. And it's for that reason that we partnered with Blue Cross Blue Shield of North Carolina, who we think are very innovative by virtue of actually developing an e-visit policy and reimbursing physicians doing video appointments for their own patients. One of the things that we observed when we started building TouchCare was, Teladoc and American Well and others out in the market, Doctors on Demand, have the ability to charge a consumer $40, $50, around that price, dollars for a video appointment. Yet my own primary care doctor can't do that. So it's kind of ironic that I can hop on an app and speak to a random doctor and pay $50, and yet I can't speak to my own doctor for the same situation, things like highlighted, pink eye, low acuity issues, and my doctor can't get reimbursed for that. So what we've done is taken the approach of, well, we're just a mobile startup. Let's partner with leading institutions and payers and help figure this out together. How do we help figure out a situation where all of us in the room here can speak to our own provider for what a provider is an appropriate use of telemedicine on the TouchCare platform? We've been very lucky to work with some folks within the UNC Physicians Network, with an ACO, for example, Cornerstone Health. Like I mentioned, with Blue Cross Blue Shield, who we think are really innovative in putting together an e-visit policy that reimburses providers with video appointments with their own patients, with Mount Sinai up in New York, and with many others that we have not listed in this slide. The interesting thing about TouchCare is all the use cases that we never dreamed of. We thought TouchCare would be used mostly by doctors with low acuity illnesses. What we've found is that doctors are downloading TouchCare on their own because it's free and simple to set up, and using it in whatever case they feel fit. We've had emergency medicine doctors using TouchCare at bedside to invite patients for follow-ups 2 days later to prevent readmissions. We've had other doctors use TouchCare for chronic disease management with patients. We've had gastroenterologists, neurosurgeons, and heart surgeons using it under a global rate for follow-up 3 days after exit. And we've also had other kinds of providers like nutritionists, acupuncturists, alternative medicines using TouchCare. And what's really interesting is that for a consumer sitting on the phone, all providers in one place. All a consumer has to do is log on to TouchCare, click on their provider's profile, and dial their provider's office to schedule an appointment. And this is a really important thing about TouchCare. When we built TouchCare, we built it so that providers would not change any of the workflow in the clinic. They chart the same way they've always charted. They schedule and calendar the same way they've always scheduled and calendared. They bill the same way they've always billed. We've integrated it so that TouchCare works with any EHR, any EMR. It doesn't matter whether the provider's on Epic or Allscripts or Cerner or Athena Health. TouchCare works seamlessly in the clinic. So our message to consumers now is a pretty simple one. It's on the slide 11 in front of you guys. Car seats and waiting room or cozy sofa in your living room. TouchCare is video own doctors. And what we hope will be the case is that consumers will start walking into their provider's office and saying, are you on TouchCare? And if their doctor's not on TouchCare, they can just invite them with a simple click. So to summarize, TouchCare's vision is to make mobile health really, really easy. There's no upfront cost. There's no deployment required. There's no integration. There's no change to your clinic or practice workflow. And providers can use their existing EHR and billing. And our hope is that TouchCare will become the leading mobile health solution out in the market. Thanks very much, everyone, for listening. Any questions, you can email me directly at dg@touchcare.com.
Thanks so much, Damian. Our next speaker is Vice President of Provider Engagement Strategy for Anthem, Inc., and also General Manager of Live Health. John?
Hi there. and thanks for having me on as well. Appreciate being in such great company, talking about something. I feel like we're, in a way, we're all singing from the same hymnal, which is probably a very healthy thing to do right about now. So I'll talk to you a little bit about how telehealth is being deeply integrated into the payer, in the example of Live Health Online. So I've been with Anthem for 21 years and just sort of saw this technology emerge about 4 or 5 years ago. We're working with a company, American Well, that actually created the technology. And for years, doctors have said, why don't you pay us for telephone visits? A lot of work on the phone. And, as payers, we've said, well, we really don't know what happened on the phone. Was it a 5-minute call? Was it a 30-minute call? Is there documentation? Was there a prescription? So finally, come technology that really creates all those things that go on in an office visit, including the live video communication, but things like ICD-9 codes, CPT coding, clearly identifying the patient, identifying the doctor, so that from a health plan perspective, yes, this makes a lot of sense. We really should make this a covered benefit. It does 3 things that we're all trying to do. It improves access to care, it makes healthcare more affordable, and it improves the consumer's experience. And so we have really 2 business approaches to this. One is the urgent care in a cloud that you've heard some about on this call already, and that's really when your doctor's not available. Because there are times, whether it's Friday night at 10 o'clock or morning at 7, when your doctor just can't be available all the time, or you're out of town, out of state. And so that's Live Health Online, which is this. Within an average waiting time of 10 minutes or less, right now around 3, you can be face-to-face with a board-certified doctor in high-definition video on a smartphone, tablet, or computer, or if your employer has offered a kiosk, and have a visit. And that visit can include a prescription, depending on the state that you're in. There's a full-blown map on livehealthonline.com, which is, I know, one of the challenges we're all dealing with. So right now it's live in 44 states, 24 hours a day, 7 days a week, 365 days a year. So that's what it is. We've been working in collaboration with medical boards in many states. I've personally been probably in 25 or 30 medical boards, helping them modernize their rules on telehealth. We're also, as many on this call, active in Washington as well. We are co-owner of a national telehealth provider group management company. We realized early on that to provide real urgent care 24/7 across the country, a few hours here from a doctor who had some spare time was not going to do it. So there's a dedicated medical group of doctors who practice telehealth for a living now, and many of them have multiple state licenses to deal with that issue, and they're handpicked and groomed and trained for telehealth. So it's really the Net Promoter Score and all the things mentioned in the past, and Dr. were are very positive. People love it, especially the mother who's busy on a weeknight. It's 9 o'clock at night. One of the children have a rash, and she's trying to figure out whether or not the next day to get a pediatrician visit, pull the child out of school, call herself out of work, and make it all happen. And then she finds out that she can download a free app or go on the web and within about 15 minutes have it all done. Those are the raving fans, and so we're happy for that. But what we saw as a health plan was this really should be a covered benefit. So we integrated it. Let me advance the slide here for a second. So we knew that it had to be paperless for it to really work well. So the first thing that happens when you go in is it checks your insurance eligibility benefits in real time, and it'll come back and know whether you're covered and if you have a copay, and it'll only collect that on your credit card. Deductible, the deductible hasn't yet been met, so it'll take care of that and charge you the appropriate amount, and then submit the claim electronically to the health plan in the background after everything's done. That was really important. Other ways to integrate it with the health plan to help employers really get optimal value is tying it to things like the 24-hour nurse line. People call the nurse line, they're automatically usually calling for a reason, not feeling well. That nurse may detect that they need to see a doctor. Again, their doctor may not be available. Rather than have it wait till morning, if they can get them connected to Live Health Online, they can get them a visit right away, and that's been very successful. After the visit's over, the patient, for continuity's sake, with one click can forward a summary of the visit to their doctor, or they can download it and print it or save it and access it anytime they want in their Live Health. Mobile was really a big deal, as all of you on this call I'm sure know. Started out with the web, but about a year and a half ago, introduced mobile app on Apple and Android devices, and now really more than half the visits are on mobile, and that continues to grow. The other thing people are able to do, it's fully integrated with the Apple Health app, so if you're tracking glucometer readings or other clinical biometrics and storing them on your Apple Health app, when you go to see a doctor, you're able to, with one click, have that information uploaded and it's made available at the time of the visit for that doctor to have it handy. I think as more and more app makers start to write useful apps to the health app, that'll increase it in value. We'll all see how that goes. We've seen this growth. I think 2014 was the year of awakening telehealth. 16 million Anthem members will as a benefit by the end of 2015, and 20 million by the end of next year. Nearly 60% of large employers with Anthem will have it as a benefit by 2016, by the beginning of next year. So again, the integration and covering it as a benefit was really important. In 2012, Anthem was the first health plan in the country to offer these visits as a covered benefit, and we offered it to all fully insured and self-funded members, including exchange members, with a rollout that began then. And then since then, in 2011 of this year, offered it as a benefit to senior citizens in the Medicare Advantage program in 12 markets. So even though traditional Medicare does not yet recognize this type of telehealth as a benefit, and I know there's a lot of conversation going on, we didn't really want to wait and kind of withhold this for seniors who may find it very convenient. And so as a supplemental benefit. And there will be expansion of that coming in 2016 with more Senior Advantage members and markets. As far as large clients, employers, we all can remember about years ago, this started out as a couple of questions maybe in a request for proposal. Now there's, full-blown 200-question telehealth proposals that come out, or requests for proposals. So there's not an employer today who at least hasn't heard of it. But of course, there's a spectrum, and those that apply the energy to help their employees adopt this and make use of it, find that they find healthcare savings that come from it. That'll only increase. It's going to be just a matter of a few years, and this will be as common as a retail clinic and anything else. There's a second part to this, and that's the provider strategy. A little bit similar to what you just heard, and this is enabling the doctor to empower their own practice and make it web and mobile enabled. So we're working with practices, predominantly patient-centered medical homes and ACOs, to let them set up a private storefront, have functionality to invite their patients in via email, and to offer themselves on web or mobile to their patients. And again, the use cases go beyond after-hours care, really get into managing chronic disease, and avoiding unnecessary travel and waiting room inconvenience, especially for seniors that have trouble coming and going from the office. So in short, the provider version of Blue plans in particular to really empower the ACO and the patient-centered medical home model with a powerful tool. And it also helps the physicians. There's incentives for them. It helps them empower them do better on their gain share. We've commissioned a company called HealthCore, which is actually an Anthem subsidiary. It's a health analytics company to do a thorough study, and we'll have that published probably in the fall, and that'll be looking across all the patients that have had visits and used telehealth, and then looking at all their claims data in relation to it, and drawing conclusions about quality and about cost and so on. So that's a real quick overview. Again, it's John Chester, and I'm happy to answer questions after we're done. Thank you.
Thanks, John, all three of you for sharing those interesting and promising examples of your telehealth initiatives. Closing out our webinar today before our Q&A session and moving us into a discussion of the policy barriers and facilitators to more widespread access to telehealth is Mario Gutierrez, Executive Director of the Center for Connected Health Policy.
Thank you, Catherine, and thank you for this opportunity. The Center for Connected Health Policy is let's see here. We're an independent public interest organization that strives to advance federal and state policies. We are a nonprofit, and to that extent, we're not a member organization or receive any funds from industry. And so to the extent that our efforts, as we were funded by the California Healthcare as our core supporter and continues to provide support to be a place where policy and information related to telehealth could be made available. In 2012, we applied for and were successful to receive a grant from the Office of the Advancement of Telehealth to be the National Telehealth Policy Resource Center. And to that end, we maintain a very active website. It's probably the most comprehensive website in the country related to telehealth policy, and basically any information that you may be interested in related to telehealth. We're part of a network of 12 other regional telehealth programs around the country that provide support. And so to the extent that you're in any one of these areas, you should contact your local telehealth resource center for support, as well as the other National Health Policy Resource Center, the CTAC, which provides assistance related to technology. As we think about the policy world of telehealth, and I think it became very clear in our presentations here today, policy is not just public policy, but it also involves the decisions that are made by health systems and by provider plans. And as you can see, there's been a lot of creativity, a lot of support for embracing this world of telehealth. But in our work, we found that the single big obstacle for the advancement of care in telehealth has been the slow response from the federal and state policymakers to embrace telehealth care and to remove the barriers that currently exist that are unnecessary and to provide guidance in terms of reimbursement and other areas. We also believe that the influencers of these policies, both for federal policy and state policymakers, as well as to the private sector, has to come from both the changes in the technology world and from consumer demand, as we heard, but also very importantly is research. We believe that, and certainly policymakers are constantly asking for the evidence. And so to that end, we at the center have spent a considerable amount of time combing through the research and producing certain standards to be able to assess and compare studies, and also to ensure that they're in line with the triple aim of outcomes of quality, cost, and better patient experience. And so we're producing these studies so that they are available to policymakers to be able to go back and see what evidence there exists. Now, this is a particular one we just did on remote monitoring, and we have 3 others. It's really important, I think, to ground our in the evidence. The evidence is clear in many areas and continues to grow. So we've heard a lot about the triple aim and the importance in the context of how states and federal government are thinking about policy. The area that we think there's tremendous opportunity, and we've touched on a little bit on that on this webinar, has been as we move out of a fee-for-service cost-based reimbursement system where it's standalone care, illness care is what drives the services, into a more value-based pay-for-results, the opportunity to utilize these technologies is much more available. Certainly, you can incorporate costs into your per patient per month, and as we heard from our colleagues in Florida, being able to fully embrace telehealth where you're not inhibited by the fee-for-service. It also is critical in the context of federal policy related to the Affordable Care Act and the creation of patient-centered medical homes or person-centered health homes, as we like to call it, to be able to connect a team of healthcare providers in a virtual way, particularly for rural communities. This is critically important, and also for wellness care. As we move on to state policies, we, as part of our federal grant, spent a considerable amount of time combing through all the laws, regulations, and policies of every state in the country. As we were going into our work with the federal grant, we discovered that there was just not a single place anywhere where this information is available. Given the fact that this is the single biggest barrier, we felt it was important in terms of our public service to make that information available. And so on our website, and this is a shot of our website, you can see we have an interactive map where you can click on any state and according to 12 different categories, be able to determine what the laws, regulations, and policies are. You could also compare state to state. Our work in this area touched on a number of key areas that we feel are important. Is it defined as telemedicine or telehealth? That the movement toward the utilization of terminology of telehealth helps to incorporate other fields where this technology has been important, whether dental care, mental health, social services, substance abuse, any healthcare is being provided, virtual technologies coming into play. And so to that extent, it could be incorporated in statute. How is it reimbursed? What kind of modality, whether it's remote monitoring? Do we have reimbursements for more than just video conferencing? Online prescribing is becoming more and more important. Issues around consent, cross-state licensing, et cetera. All these are areas that you can go to. And we also provide the source information so that you can click back to see where we found that information. There's not enough time to go through all of our findings, but I just want to click on some of the key areas that we found. Certainly the live video is the most common. What's most important, I think, about this side and most telling is that there's still 4 states in the country who do not reimburse even for live video under the Medicaid programs. Store and Forward, which probably has some of the most compelling evidence in terms of cost savings as well as quality of care in the areas of dermatology and in ophthalmology with diabetics. Only 9 states reimburse for that form of care through the Medicaid programs. And then remote monitoring, as we heard today, critically important for monitoring of chronic diseases and keeping people healthy at home, particularly the elderly. Only 14 states to date have any form of reimbursement for remote monitoring. Another area that's getting a lot of attention has been this whole notion of payer parity. As we heard, there's some concern about having any mandates related to how health providers or payers are doing this, and I think that there's a lot of language out there, and I think even though 27 states have passed some form of private parity laws, they're not all the same, and I think it's really important for your particular state to carefully the language. Many states use language that speak to the terms and conditions of a contract of a payer, which provides the payer with the ability to determine what and under what circumstances they will reimburse for telehealth. Online prescribing is a big issue, particularly when we're talking about virtual care, things of the kinds of services that we've been hearing on this. In our research, we found that there are just a few states that actually allow explicitly in law or in regulation the prescribing without a physical examination listed there. Texas is going through some litigation, as many of you may know, so that's one that's a little bit more complicated. Minnesota and New Hampshire actually have specific language that prohibits the services of telehealth and virtual care without the in-person examination. Some of the more positive trends that we have noticed in the world of state policy is this effort to move toward a more comprehensive definition, as I mentioned, for telehealth. California, Nebraska, Wyoming, and I think obviously reimbursing for all forms of these technologies, store and forward, remote monitoring, and including those explicitly in legislation, regulations, and in those Medicaid manuals. Clear guidance to private providers. I think that's come clear in this webinar. There may be some ambiguity in terms of laws. I think it's really important that private providers understand, whether it's within the exchange or directly, what the rules and regulations are related to telehealth in that particular state. And then the question of out-of-state licenses is also getting a lot of attention. Some areas of concern, I think that it's really important that makers start to develop and write language related to telehealth, that they consult with groups like us and others to ensure that the language is clear and consistent and not contradictory. New York just went through a situation where what was some very fairly progressive legislation on telehealth, but within the language there were some elements that had to be cleaned up through amendments. Also, we're seeing some disturbing trends in the context of rather than removing, that some states are now actually starting to regulate telehealth and adding more barriers. So particularly when it comes to having to demonstrate that there's no provider available, or that it's an undue burden for the patient, as we see in the Connecticut bill that we were just looking at. Just a few words on interstate licensing. This is probably one of the, in terms of practice, one of the biggest inhibitors of the expansion of telehealth and virtual care has been for physicians to be able to provide consultation across state lines. And so to the extent that the Federation of State Medical did an interstate compact that has now been passed by 9 states. They required 7 to activate that compact, and 9 other states that are considering that. This is a step forward. To be clear, it is not a telehealth license, but rather a simplification of the process by which physicians can apply for licenses in other states. We've seen more activities in the last few months and than all of last year in terms of legislation related to telehealth. I think this is a good thing, particularly when it comes to clearly identifying reimbursement and areas of licensing and definition. Just a couple of words on the federal policy. Medicare is outdated. The fact that they're still stuck and only reimbursing for live video, and only for those patients who happen to live within a clearly defined health professional shortage area. It's time for Medicare to reassess and make these new technologies available, particularly for seniors' health and embracing remote monitoring as a real way of not only improving the quality but significantly reducing costs over the long term. There has been some encouraging efforts on the part of CMS in terms of moving toward more value-based care. I think Karen DeSalvo made a very good case, and clear that we're moving in that direction. Although there have been some recent language in the final rule for accountable care organizations that actually does not go far enough in terms of allowing for the use of telehealth. And to that extent, there have been a few code changes that I think are encouraging. A new code for non-face-to-face chronic care management and coordination, but there's much more that needs to be done. And then finally, I think on the federal side, the language in the next generation ACO, I think, really points to the future to allow for greater access for the broad range of services, including skilled nursing facilities, and to actually allow for incentives for the uses of these kinds of technologies and remove any form of geographic restrictions. Unfortunately, only 20 pilots will be funded in the first 2 years, so we still have a ways to go before we see these kinds of transformations take place within the Medi-Cal program. And with that, I'd like to thank you for inviting us to be here. Here's our website, and we certainly invite you, if you have any questions related to policies, either at the state level or federal, to please contact us, and we'll be happy to help.
Thank you so much. We're excited to start our Q&A session, and at this time I'd like to ask our operator to come on, and he'll explain how you can ask a question over the phone. Also try to answer a few of the questions submitted online.
Remind everyone to ask a question. Please press star and the number 1 on your telephone keypad.
And while we wait for the phone questions, we can start with the first question. And for Senator Frist, what are the 3 most important legislative and regulatory changes that need to take place at the federal and state level so that telehealth can reach its potential to improve patient outcomes at reduced costs?
Catherine, good, thanks. Mario just did a superb job outlining and actually going into depth on the scope of legislative challenges. But listening to him and sort of jotting down notes, if you asked me to list my 4 based on my experiences in medicine and in the telehealth field and in Washington, D. and CMS, I would list them like this. Number 1, and again, Mario hit these really perfectly, requiring duplicate licenses and maintaining separate practice rules in every state. It really has just become a barrier for telemedicine that's got to be addressed. The state approaches keep people from getting the critical and often life-saving care. There are a whole bunch of options that have been proposed for licensure, including interstate compacts, which I mentioned, based on mutual state recognition. And you could even go to a national standard. Congress, with bipartisan support, expanded the whole exemption from multiple state licenses for the Department of Defense health care, where one state license is now sufficient throughout the country. The whole idea of one state license could be expanded to other federal programs. Number 2, an increasing problem for telehealth is and again Mario mentioned it, the state medical boards adopting practice rules with higher specifications for telehealth than in care. And I mentioned that, and it's something that just has to be addressed by state. It's education, is changing culture. And then number 3, right at the end, Mario mentioned the barriers in Medicare and Medicaid. This is where CMS can move aggressively and quickly, and I would encourage everybody to get in touch with CMS, help them work with them. And then the last one, again, Mario mentioned it, I think there are 22 states, I've forgotten exactly what you said, Mario, that state-regulated health plans reimburse for telemedicine services the same way, or the same amount that they pay for face-to-face. We got to encourage that. It's just not fair, and several people, Damian mentioned it as well, it's just not fair to the physicians who are delivering care, the same sort of care, some getting reimbursed and some not. So that would be my 3, and I added the 4th.
Great, thank you so much. Ian, do we have any questions on the phone?
For the phone.
Okay. We had a few questions come in online about sort of the level of uptake among the Medicare population, just with use of smartphones or uptake of telehealth technology, as well as a specific question for John on the uptake with your Medicare Advantage population. I don't know if John or any of the others would like to comment on the question.
This is John. I can make a couple quick comments. One, what we made a decision about 2 years ago, actually maybe 3, after meeting with the medical board in California that recognizes live audio as the only thing acceptable in California for establishing a relationship with a patient and a new patient, a physician that haven't met before. So we took a risk, and our solution is live audio or live video only. Again, with smartphones coming out like crazy now, it's becoming less and less of an issue. But there are some people who just want to dial. Anyway, so 100% of our visits have been mobile, and they've grown tenfold in 2014 and continue to grow. So I think that eventually will become mainstream. With Medicare, it's very interesting. We rolled it out as a benefit. We're just sort of in the process of coming up with how to best market to the senior. We're looking at those of which we have an email address for sure, and focusing on them, because this is really a digital tool. And we're looking at those that have also had repeat visits for things like upper respiratory infection, things like that are known to be good candidates for this. I'll be able to give you more information in probably about the fall or end of the year as far as how that went. So the uptake with seniors is slow to start with, but again, we really need to find the right way to reach them to promote it.
This is Karen. I would add a couple of points. One is that we do see that there are differences in consumer interest in technology as an access point for care, but in healthcare settings where the team has been working tightly with the consumer no matter the age, we actually see that can level that playing field a lot. By example, I was in Nebraska recently at a rural hospital that a lot of seniors as their patient base, a lot of Medicare beneficiaries, and they've had nearly 100% uptake of their portal, their patient portal from their electronic health record, and that's a way that not only the consumers can get in, but they can ask questions, their information. So I think a lot of this is up to us to make sure that we're not making any a priori assumptions and being sure that we're taking the time to provide education for access. But as you say, also, as everyone would know, be thoughtful about the fact that multiple platforms are going to be necessary, and we don't want to only have one platform to rely upon. And I want to add a little bit of a non sequitur, just because I didn't mention it in my presentation, and it's coming up a little bit in some of the presentations that happen now about payment rules and some of the tightness of definitions, for example, in some of the federal payment rules. And we have some opportunity going with the legislation that passed in the SGR fix, this macro bill, to think about how telehealth could be a part of alternative payment models going forward. So we're keeping an eye on and thinking about how we can allow for some more flexibility, not just within the current state of technology, but back to Nebraska. One of the things they're experimenting with there is thinking about how they can use a hologram as a version of telepresence health to bring healthcare providers literally out into the rural parts of their state that have healthcare shortages, and also in the reverse, using CAD technology to transport patients back to the academic medical center to a specialist, because they can get some pretty good resolution of wounds and lesions and other issues. So I think the world is, the technology is just taking off really quickly. Some is, leading edge and still experimental and ideas, but on the other hand, I think just seeing that what, for example, what Nebraska is doing in the space of hologram health, we, the federal government, and I think the private sector payers and others too, just need to be aware of the fact that things are going to move quickly, and we want to have a flexible policy that meets the outcome goal of better care, smarter spending, and getting that kind of access and convenience that consumers need, while also thinking about how we do that in a way that is more cost effective.
Hi, this is Damian. Could I just make one comment on the Medicare side? I think, and I'm not the expert here, our medical director, Dr. Melton, if anyone's interested, she can speak to folks. But I think CMS indicated code 99490 for non-face-to-face chronic management, regardless of the location and some reimbursement rate. But just to plug one of our customers, Cornerstone Health, who's an ACO, focusing on chronic care management using TouchCare and using it with seniors. I know that we had an 80-year-old patient using TouchCare this week for a chronic disease management visit. And so certainly in an ACO environment, that's plausible. So I think the second comment I'd make is, for me, the payer is the enabler of telehealth. It's not TouchCare, it's not American Well, it's not Teladoc really. The real enablement is the reimbursement. The consumers are smart. Consumers will choose the tool that they want to use, and providers will choose the tools they want to use. That's really a free market. So I guess, as entrepreneurs, payers can bring to the table is not designing technology solutions, but it's enabling reimbursement, enabling providers to be able to engage with their own patients remotely. That's sort of our take.
And we do now have questions from over the phone.
Okay, great. Thank you.
First question comes from Michelle Chagwar. Your line is open.
Thank you for taking my call. We at Northern Virginia Community College wonder what college and community colleges can do to prepare the workforce of the future today to be prepared for careers in telehealth.
Well, this is Dave TouchCare. I think the first comment I'd make, every single one of your students communicates via their mobile phone. They live on their mobile phone. They FaceTime each other. They text each other. They probably don't phone each other. So I think we're sort of halfway there. So the real answer is then the professional training on the provider side, because guaranteed that those college kids, when they get out, are already communicating and sort of talking to each other this way. So it's completely a question from our view of working with residents, working in the training and the sort of curriculum of integrating telemedicine and e-visits into the way that providers are trained, whether it's from nurses through to specialists.
Thank you.
And our next question comes from the line of Kevin B. Your line is now open.
Hi, thanks so much for taking my call. I'm actually an emergency medicine physician with dual appointment in geriatrics in North Carolina, and I frequently use mobile health with my older adults and follow up using the TouchCare platform that Damian referred to. My question is really, I think, to our Assistant Secretary from HHS, and that is thoughts on how to keep mobile health safe for older adults if they're working with providers that don't know their patients. I think that for older adults, they're really vulnerable if they're on many medications, and working with doctors who don't know the distance obviously increases risk. And I just speak on thoughts how to make sure it's safe when we're working with providers who don't know the patients.
Thank you for the question, and I just have to tell you that's the first time I've ever heard of somebody being duly boarded in emergency medicine and geriatrics. It's an incredibly interesting combination. I bet you have a rich experience. And to your point about follow-up after folks leave the emergency department, my husband's an emergency room doc, and so I know a lot of times you all spend hours with seniors in the ED and get to know them pretty well, and so you have this very special insight into the family and the challenge. So just in general, thank you for really caring about aftercare for them. I bet it means a lot to them and helps their outcomes. With respect to the mobile technology, one of the challenges we're facing in the interoperability space is not just how to have the electronic health records talk to each other, but how to create a technology and policy platform that supports all the inputs from all the various technologies, including the mobile kinds of technologies, remote sensing, a scale for a patient with heart failure or sensors for folks. And that there are some commercial platforms that are showing some promise. I think that overall what you're describing is what I hear a lot from consumers and doctors is they want a more fulsome picture of the integrated information about a person, not just the clinical care visit from the EHR, but how do you integrate data from the remote sensing at home? How do you make sure also to data so that there's clarity about the origin and important for the doc and for the patient. And for the doctor's purposes, how do we give you a picture of all the other sources of information and input that are coming perhaps from other prescribed health devices? As I said, there's some commercially available platforms that are showing some promise. It's what we talk about in our policy development. For us, it's really getting down to some clear shared standards so that we're all using the same data vocabulary, data dictionary, so that it is easy to integrate all that data and giving the patient and doctors and the empowerment to merge and share that information with the patient or where appropriate under HIPAA. And so this is going to become a huge issue in the future, especially because of the evolution of these sensing devices like the wearables. And for seniors, we're seeing an awful lot of interest, demand, and expectation that we can do remote sensing, not just of things like weight on a scale, but use floor sensors and wall sensors and other cues that tell us if somebody is physically active one day to the next, and if their gait is slowing down or changing in some way, even to look for drug side effects. So I think that we're just beginning to understand the potential use cases, but I think you're right. We also have to understand how we have a complete picture of that data, and we don't have technology interactions like we sometimes can have drug interactions.
Thank you.
This is Mario. Let me comment on that as well. I think another aspect of this in terms of emergency department care is the physician-to-physician consultation and the importance of having the availability of specialists that can work with physicians in rural hospitals. We just reviewed a study from University of California Davis Medical Center using pediatric intensive care with rural hospitals that has proved to be incredibly effective to allow that family to be able to have the confidence that their child is being taken care of by one of the best specialists, pediatric intensivists in the country, without having to life-flighted. That is such a great value not only for the patient, but also for that primary care or emergency room doctor to be able to have that consultation in real time in a distant location.
Thank you. Ian, are there any more questions?
There are no further questions on the phone.
Great. Well, we are at the 2:30 mark. I would like to give our speakers one last opportunity if there's any closing comments that anyone would like to make. And we will be making a recording of the webinar available. I know there was a little bit of technical difficulties with some people listening, so I do apologize for that. Anyone like to make any closing remarks?
Hey, this is John Jesser with Anthem. I just want to offer to other Blue plans on the line that we're very happy to collaborate and work with you on sharing best practices and sharing solutions. So feel free to reach out to me directly through information on this website or just at Anthem, john.jesser@anthem.com. Thanks.
And Catherine, this is Bill Frist. Just want to thank the NIHCM Foundation and Karen, Howard, Damian, John, Mario, and everybody for participating. It's been educational for me, and without these sort of webinars, it's just impossible to get this kind of information at this schedule level. So thank everybody for sponsoring and putting this on.
Hey, Bill, it's Damian. Just wanted to echo the thanks, and especially to thank Blue Cross Blue Shield North Carolina, Howard, you guys at Florida Blue, and a bunch of the Blues who I think are being really innovative partners in advancing this stuff, including Anthem. So I appreciate all you guys' help on this stuff.
Yes, Howard Rochay for Florida Blue. Again, just to say thank you to Catherine and team for organizing this and putting everything together, and appreciate the opportunity to present.
Great. Well, thank you to you all for being with us today, and to our audience. Please take a moment to provide feedback on this event. There is a link in front of you, and thank you all again.